Good morning, everyone. I'm Dr. Shruthi, and I'll be taking you through a very interesting topic, ocular pathology, importance of appropriate tissue sampling. Right. So, just to give you an overview, so what do we pathologists do in an ocular pathology lab? Apart from looking at the biopsies that you send, we also do a lot of cytology. We do frozen sections. We do IHCs. IHCs both for diagnosis and prognosis. We do immunofluorescence, and also if you are lucky to be in a big institute with a research center, we also do a lot of flow cytometries, tissue arrays, and electron microscopy. So what samples do you clinicians send us? So we receive enucleated eyeballs, we receive excentration samples, eviscerations, Thicicle balls, map biopsies, biopsy of the lid. So I'll skip the other cornea and the retina thing. So what basically I'm going to talk today is how we receive the specimen from the patient's body to the report getting delivered into an envelope. So I'm going to talk to you about the journey. I'm not going to bore you with the pink and blues and try explaining all the pathological features. It's not required. So this is more of an interactive session, and just a little SOPs and protocols is what I want to highlight, because sitting back as a pathologist, this is where we fall short of communication. Most important is a duly filled request form. So this is just a sample from our hospital, but then what's important is not everybody who is practicing oculoplasty and ocular oncology is privileged to have an in-house ophthalmic pathologist. So very important. So that is the communication what you're doing with the pathologist is through this form. So apart from the routine, so many time they feel that just writing the patient's name and site, your work is done, but no, the clinical summary, the history, some information to us about what you're thinking, so that we can match up with the clinical diagnosis, and it gives us a channel to think, and then also let us know about the imaging findings, any microbiology findings that will help. And also at the time of surgery, if there was something different that you saw cheese wiring, you saw some bone erosions, you saw periorbital reactions, so please put it up. So that's going to help us as well. And a small diagram again with some colors if you have, that will also help us a lot. So I'll just describe each sample and the pitfalls what we feel as a pathologist. So those are the things that will highlight. So excentrations we'll start off with. So I won't go to the indications and all that. We know, so you know that very well. So what I want to highlight is this is how we receive the sample most of the times. We receive a huge sample in a very small bottle. So please remember the ratio of formalin and the sample should be 1:10. So this formalin should be 10 times. And mind you, this is not concentrated formalin. Please remember, you should put it in a 10% neutral buffered formalin. Most of the OTs just have concentrated formalin. It does affect the morphology, and especially when we do IHCs, we get aberrant expression. So please remember to ask your OT technician, or if you're outsourcing it to a lab, is this neutral buffered formalin or concentrated formalin, and please maintain the ratio. Sometimes I get such a big bottle with a very tiny corneal button, and they put like 20 times formalin. That's still okay, but then larger samples always 1:10. And then in an excentration sample, very important, please mention if it's an eyelid sparing excentration, complete, partial excentration, because sometimes we get samples which are totally distorted. Cutler beard is done prior, or there's a huge ulcer. We really, we can't make out the eyelid, the upper eyelid, lower eyelid, so please mark it out for us. And also again, some people, some ocular surgeons, they prefer sending us the orbital apex tissue or the posterior tissue separately for us to comment. That will be great. Otherwise also, just put some suture material and mark it out for us. Very important to mark the nasolacrimal duct area, because that is the residual lesion, and we have to comment on it whether there's any residual tumor left in this region. So that is again important in an excentration sample. So once we receive the sample, so we usually ink the surface. That's very important. We probe the NLD area, we sample it separately, we sample out. So again, it was very challenging because for the first time when we started receiving excentrations for orbital rhinomucormycosis, and then we had to give you the margin clearance, frozen clearance. So again, marking helps a lot. So this is how we bread loaf it and then submit it for processing. Moving on to enucleations. Now enucleation, most common indication, it's done for RBs, it's done for melanomas. So what I want to highlight here is marking of the vortex veins, and also in your OT, please measure your optic nerve length before you send it across to the lab. Sometimes we receive specimens which comes from courier or post and takes many days together, and the optic nerve tends to shrink a little, but then always do a documentation prior and mark the vortex veins, because that's again important for us to comment on it. Also, sometimes we receive samples like this in our lab, where a tumor sampling is prior done, a scleral window is made and sample is taken out for research purpose, for molecular diagnostic. But please inform the pathologist, keep the pathologist in, when you're doing this, please call them, show them, and it's always better if you do this together. Please don't do this and send the sample across. So what happens is, this, if the pathologist is doing without knowing, then we falsely upgrade the tumor. We would have given, because when you cut and remove the tumor, some amount of tumor just tends to slip away in the sclera. So we high grade the tumor, and then that affects on the child's chemotherapy. So ideally, a scleral nick should be done, sampling should be done, and it should be sutured back and mentioned on the request form. And we also get samples like this, very surprisingly. You can see there's a large exophytic tumor of RB sitting, and look at the optic nerve, really short and small. Becomes very difficult for us to comment, and it's again very scary to comment on this thing. So please make sure you give a long ON nerve. If not, please refer these cases to somebody who can do it well. So ideally, this is how the sample should be. You can see how long the optic nerve is there. And this is ciliocoroidal melanoma again. So I think Dr. Shefali has already touched upon this. So I just want to mention that whenever you send us OSSN samples, so excise the lesion, put it on a Wattmann's filter paper or a cellulose acetate paper. Even the glove paper works very well, it sticks on it. Let the hemostasis take some time and stick. Don't immediately put it into formalin. And please mention us send us with the marking. Even better if you separate out the margins and send it to us. Otherwise, it's fine. We can always just mark the margins. We can always cut it across, and we can separate the margins. And she's already highlighted the base, or if you suspect that some scleral fixation is there, please send that separately in a separate small vial or a separate paper. That helps. Map biopsies, again, we see map biopsies for SGC, we see map biopsies for a PAM. Very important, please write the numbers and then you can stick on the biopsies. Don't send them like this, because what happens is, for an ophthalmic pathologist, it is easy to make out whether this is an upper fornix, lower fornix, bulbar, palpebral conjunctiva, but if you're sending them to a general pathologist, then reporting will be a mess. So this is how we usually report a map biopsy, and we comment on the pituitary spread. Eyelid tumors, again, ma'am has already touched upon. So this is how the tumors come to us, and we separate out the margins, we bread loaf it, and then we have to comment on the depth of involvement of the tarsal plate. Frozen section, again, what is frozen section if somebody is new to this? So it's a rapid intraoperative tumor diagnosis. So the patient's there waiting for and the surgeon sends it to us, and within 30 to 40 minutes we give them the report and tell them whether it's a benign lesion or a malignant lesion for them to complete their surgery. And remember, this is not to be sent in formalin. Better to directly go and give it to the pathology lab. If there's a resident, they can come with the sample, show us the clinical image, orient it to us, because again, putting it into the frozen section machine, we need somebody to orient the sample for us. Orbital biopsies, again, we receive incision biopsies, we receive large tumors, excision biopsies, and now recently we are also receiving multi-layered biopsy. This is the same sample. There are 3 layers of biopsy for the same patient, and we have seen that superficially we might miss the lesion, but the deeper portion of it will have the pathology. So always prefer for a multi-layered biopsies, correlate it with the radiology and send us samples accordingly. So our mentor Dr. Geeta always tells us that whatever happens in this 5 feet of human body can easily occur in this 5 centimeter of orbit. So we receive a very tiny biopsy. Throughout our PG residency as a pathologist, we never see these small ocular specimens. Only if we get trained, only then we get used to it. So for a general pathologist, a tiny biopsy is very challenging, because when it's large specimens, we don't care. We go multiple deeper sections, but here in 2-3 deeper sections, we just exhaust the tissue and the tissue is gone. So it's very important to communicate and to send appropriate biopsy. Just want to highlight this case. So no offense, disclaimer, this is from a pathologist perspective that I'm telling you. So this was a 56-year-old male patient, very well-educated person. So he was referred from an ophthalmologist to our institute, and so our fellow did perform the surgery, and it was on the imaging suspected orbital inflammatory disease or a lymphoproliferative disorder, and this is the biopsy that we got. So as a pathologist, you can see the slide, just show the external part of the slide, not what I see in the microscope. So we're seeing some stained tissue there, and it's a little pink, not blue. So whenever it's blue, so as soon as I reach my table daily in the morning, I just see my trays grossly. Whenever it's a lot blue, I just pick those slides first, because I know I'm looking at a malignancy, because there the nucleus is more and it tends to be rather more blue. But here it was little pink. And when I looked into the microscope, what did I see? So I saw a large cartilage, some fibrous tissue and fat there. Again, the whole biopsy was like that: cartilage, fat, some non-specific ducts, and then only one small part had some crushed cells. So this was the biopsy for us, and with my experience, I know that yes, this is not a representative biopsy. So I'm fortunate enough to be in an institute where we have an EMR axis. So just I go look upon the axis and pull out the images. So there's quite a large mass there. So I know that this is not a representative biopsy. So what I did, this was my report: biopsy is not representative, and kindly correlate again and send us a repeat biopsy sample. This doesn't go well with the clinicians most of the times, and sometimes even with the patients, So our patient went back, he took the sample back for a second opinion, and guess what? So this was the review: immature teratoma, because the other pathologists saw a lot of fat cells, a lot of ducts and cartilage there. But for an ophthalmic pathologist, no, I know I'm looking at the trochlea of the superior oblique. So it's very important to get back. So we somehow managed to convince the referral doctor. We told them all the points, and finally the patient did agree for a repeat biopsy, and this was the biopsy. Yes, we were looking at a EMZL, and this time you can see the slide from the outside, it's a lot blue. So what is the take-home message? Good pathology begins with good sampling. So adequate sampling is needed for HP, and again IHC. Mind you, Dr. Firoz already mentioned that in lymphomas, we run at least a minimum of 9 to 10 markers. So each marker we have to cut the slide, go deeper and deeper. So each slide one marker. So we need some good amount of tissue, not very tiny bit of tissue. And the sampling starts from you. So the good report is in your hands. So how well you orient the tissue, how well you handle the tissue. If you're handling the tissue quite roughly with a serrated forceps, that itself gives a lot of crush artifacts that makes it difficult for us to interpret. The fixative you use, I already mentioned, never use concentrated. And if you're sending specimens in normal saline, please mention that to us. Many a times, sebaceous gland carcinoma versus SCC, they send it in normal saline, or they send a fresh sample for us to perform oil redo stain. So in those cases, please let us know. Otherwise, the person just comes and keeps it on their desk and goes, and it just keeps getting denatured. So it's always important to just give a call to the pathologist. So proper site and orbital inflammatory disease, everybody now knows the importance of doing a biopsy. Dr. Fair has already highlighted on that. Steroid holiday before you perform. So the patient is hunting, the patient is going to places already. There are doctors who have put them on a lot of systemic steroids or local steroids. So please give a break, give a good 2 to 3 weeks of a holiday, because steroid induced fibrosis is very notorious, especially in tumors like IgG4. So we get false positive results. So please wait and then perform a biopsy. Communication with the pathologist is the key. Just takes few minutes, and please give them access to imaging. Whenever there are difficult cases, send across the image. Of course, we're not as good as you guys, but then it gives us a direction to think and to report. And multidisciplinary teamwork, always us, you, the oncologist, the radiologist, and the radiotherapist, we all are there for the patient. Thank you.
Thank you so much, Shruthi. I mean, it's not easy to cover everything in 12 minutes, but you did a good job. And thank you for your contribution.